Peripartum Cardiomyopathy. Dr. Akram Al-Qadra, MBBS, FRCPC, Fahar. Introduction. Heart failure during pregnancy was recognized as early as 1849. First described as a distinctive form of cardiomyopathy only in the 1930s. In 1971, Damascus described 27 patients with the disease and named the syndrome peripartum cardiomyopathy. Introduction. The European Society of Cardiology recently defined peripartum cardiomyopathy as a form of dilated cardiomyopathy that presents with signs of heart failure in the last month of pregnancy or within 5 months of delivery. Introduction. It occurs in 1 in every 2,289 live births in the United States. The rate varies in other populations. It is highest in Haiti, with 1 case in 300 live births. Peripartum cardiomyopathy is relatively rare but can be life-threatening. The rate varies in other populations. It is highest in Haiti, with 1 case in 300 live births, which is nearly 10 times higher than in the United States. The reason for such variation remains unclear. Introduction. Early reports, death rate was nearly 50% in USA. More recent reports, 0 to 5%. Earlier reports likely represented publication bias. What are the causes? Cardiotropic viral infections, chimerism, apoptosis and inflammation. Myocarditis, cardiotropic viral infections, chimerism, apoptosis and inflammation. Other possible factors: a form of idiopathic primary myocardial disease associated with the pregnant state. Several plausible etiologic mechanisms have been suggested. None of them is definite. 1. Myocarditis. Myocarditis has been found on endomyocardial biopsy of the right ventricle in patients with peripartum cardiomyopathy. The prevalence of myocarditis in patients with peripartum cardiomyopathy ranged from 8.8% to 78% in different studies. 1. Myocarditis. The presence or absence of myocarditis alone does not predict the outcome of peripartum cardiomyopathy. 2. Cardiotropic viral infections. After a viral infection, a pathologic immune response might occur. This is inappropriately directed against native cardiac tissue proteins, leading to ventricular dysfunction. 2. Cardiotropic viral infections. Boltzmann found parvovirus B19, human herpes virus 6, Epstein-Barr virus, cytomegalovirus DNA. In endomyocardial biopsy specimens from 31% of 26 patients with peripartum cardiomyopathy. 2. Cardiotropic viral infections. Leiden and Huber found that mice developed worse myocarditis if they were experimentally infected with coccicevirus and echovirus during pregnancy than if they were infected while not pregnant. 3. Chimerism. Cells from the fetus take up residence in the mother, or vice versa, sometimes provoking an immune response. Serum from patients with peripartum cardiomyopathy has been found to contain autoantibodies in high titers, which are not present in serum from patients with idiopathic cardiomyopathy. 3. Chimerism. Most of these antibodies are against normal human cardiac tissue proteins. The peripheral blood in these patients has a high level of fetal microchimerism. The peripheral blood in these patients has a high level of fetal microchimerism in mononuclear cells, an abnormal cytokine profile, and low levels of CD4 plus CD25 low regulatory T cells. 4. Apoptosis and inflammation. Programmed cell death. Experiments in mice suggest that apoptosis of cardiac myocytes has a role in peripartum cardiomyopathy. Fas and Fas ligand are cell surface proteins that play a key role in apoptosis. 4. Apoptosis and inflammation. Study from South Africa, 100 patients with peripartum cardiomyopathy followed for 6 months. 15 patients died, and those who died had significantly higher plasma levels of FAS/APO1. 5. An abnormal hemodynamic response. During pregnancy. Blood volume. Cardiac output. Afterload decreases because of relaxation of vascular smooth muscle. Cause transient and reversible hypertrophy of the left ventricle to meet the needs of the mother and fetus. 5. An abnormal hemodynamic response. Cardiac output reaches its maximum at around 20 weeks of pregnancy. The transient left ventricular systolic dysfunction during the third trimester and early postpartum period returns to baseline once the cardiac output decreases. 6. Other possible factors. Prolactin, relaxin, immune complexes, cardiac nitric oxide synthase, immature dendritic cells, cardiac dystrophin, toll-like receptors. WHO is at risk. Multiparity. Advanced maternal age. Although the disease can occur at any age, the incidence is higher in women over age 30. Multifetal pregnancy. Preeclampsia. Gestational hypertension. African American race. Clinical features. Diagnostic criteria. Cardiac failure developing in the last month of pregnancy or within 5 months of delivery. No identifiable cause of the cardiac failure. No pre-existing heart disease before the last month of pregnancy. An ejection fraction of less than 45%, or the combination of an end-mode fractional shortening of less than 30% and an end diastolic dimension greater than 2.7 cm/m2. Left ventricular systolic dysfunction in women with no history of heart disease. All must be present. 17% of cases were diagnosed antepartum and 83% postpartum. The mean age at diagnosis was 28 ± 6 years. Left ventricular function almost completely normalized in 51% of surviving patients. Interestingly, the left ventricular ejection fraction normalized only in 23% of an African cohort. Symptoms: dyspnea, dizziness, pedal edema, and orthopnea. The dyspnea during normal pregnancy is thought to be due to hyperventilation caused by the effects of progesterone. Also due to pressure on the diaphragm from the growing uterus. Dyspnea, dizziness, pedal edema, and orthopnea can occur even in normal pregnancies. Therefore, a pregnant woman in whom peripartum cardiomyopathy is developing may consider her symptoms to be normal. Symptoms: peripheral edema occurs in approximately 2/3 of healthy pregnant women. If swelling and other heart failure symptoms develop suddenly in an otherwise normal pregnancy, this should prompt further investigation. Pulmonary edema, thromboembolism, hemoptysis and pleuritic chest pain may be presenting symptoms of pulmonary embolism. Cardiac arrhythmias. Cardiac arrhythmias and sudden cardiac arrest have also been reported. A latent form of peripartum cardiomyopathy without significant clinical signs and symptoms has been reported. Preeclampsia should be excluded. Preeclampsia should be excluded on the basis of history and physical examination, as its management is different. Preeclampsia occurs after 20 weeks of gestation. Characterized by high blood pressure, protein in the urine, swelling, sudden weight gain, headaches, and changes in vision. Delayed diagnosis. Delayed diagnosis may be associated with higher rates of illness and death. Symptoms of heart failure can be difficult to differentiate from those of late pregnancy. Physicians should consider peripartum cardiomyopathy in any peripartum patient with unexplained symptoms. Management of peripartum cardiomyopathy. Heart failure treatment during pregnancy. Welfare of the fetus is always considered along with that of the mother. Angiotensin-converting enzyme, ACE, Inhibitors and ARBs are contraindicated in pregnancy because they can cause birth defects. The teratogenic effects occur particularly in the second and third trimester, with fetopathy characterized by fetal hypotension, oligohydramnios anuria, and renal tubular dysplasia. However, a recent study suggested a risk of malformations even after first trimester. Exposure to ACE inhibitor drugs proven to be safe and are the mainstays of medical therapy of heart failure during pregnancy. Digoxin, beta blockers, loop diuretics, drugs that reduce afterload such as hydralazine and nitrates. Beta blockers have strong evidence of efficacy in patients with heart failure, but they have not been tested in peripartum cardiomyopathy. Nevertheless, beta blockers have long been used in pregnant women with hypertension without any known adverse effects on the fetus, and patients taking these agents prior to diagnosis can continue to use them safely. After delivery, the treatment is identical to that for non-pregnant women with dilated cardiomyopathy. ACE inhibitors and ARBs. The target dose is 1/2 the maximum antihypertensive dose. Diuretics are given for symptom relief. Spironolactone or digoxin is used in patients who have New York Heart Association Class 3 or 4 symptoms. The goal with spironolactone is 25 mg/day after dosing of other drugs is maximized. Beta blockers are recommended for peripartum cardiomyopathy, as they improve symptoms, ejection fraction, and survival. Non-selective beta blockers such as carvedilol, Coreg, and selective ones such as metoprolol succinate, toprol-XL, have shown benefit. The goal dosage is carvedilol 25 mg twice a day, 50 mg twice a day for larger patients, or metoprolol succinate 100 mg once a day. Anticoagulation treatment. During pregnancy, the risk of thromboembolic complications increases due to higher concentrations of coagulation factors 2, 7, 8, and X, and of plasma fibrinogen. The risk may persist up to 6 weeks postpartum. Anticoagulation treatment. Cases of arterial, venous, and cardiac thrombosis have been reported in women with peripartum cardiomyopathy. Risk may be related to the degree of chamber enlargement and systolic dysfunction, and the presence of atrial fibrillation. Anticoagulation treatment. Patients with evidence of systemic embolism, with severe left ventricular dysfunction or documented cardiac thrombosis, should receive anticoagulation. Anticoagulation should be continued until a return of normal left ventricular function is documented. Guidelines. Warfarin is probably safe during the first 6 weeks of gestation, but there is risk of embryopathy if the warfarin is taken between 6 and 12 weeks of gestation. Is relatively safe during the second and third trimesters but must be stopped and switched to a heparin several weeks before delivery. Anticoagulation treatment. Warfarin can cause spontaneous fetal cerebral hemorrhage in the second and third trimesters, and therefore is generally contraindicated during pregnancy. Unfractionated heparin or low molecular weight heparin can be used during pregnancy. Cardiac transplantation. Patients with severe heart failure despite maximal drug therapy need cardiac transplantation to survive and to improve their quality of life. However, fewer than 3,000 hearts are available for transplantation worldwide per year. Therefore, ventricular assist devices are indicated as a bridge to transplantation. Patients with symptomatic ventricular arrhythmias should be considered for defibrillator implantation. New treatments. Pentoxifylline improved outcomes, left ventricular function, and symptoms when added to conventional therapy. Intravenous immunoglobulin improved the ejection fraction in several studies and also markedly reduced the levels of inflammatory cytokines, namely thyroidoxin. Immunosuppressive therapy does not yet have a fully proven role, but it could be considered in patients with proven myocarditis. Bromocriptine drugs that inhibit prolactin secretion may represent a novel therapy for peripartum cardiomyopathy. Given the various etiologic mechanisms of peripartum cardiomyopathy, it is unlikely that immunosuppression will help all patients. Furthermore, without a large randomized trial, treatment successes may merely reflect the natural course of the disease. Investigators have emphasized the need to rule out viral infection before starting immunosuppressive treatment, as the treatment may activate a latent virus, with subsequent deterioration in myocardial function. Based on this concept, 2 patients with peripartum cardiomyopathy were treated with bromocriptine, an inhibitor of prolactin secretion, and they showed a good recovery. 69 We require large prospective randomized controlled studies to prove the beneficial effect of blocking prolactin in patients with peripartum cardiomyopathy. Other proposed therapies: calcium channel antagonists, statins, monoclonal antibodies, interferon beta, immunoadsorption, therapeutic apheresis, cardiomyoplasty. How long to treat? Patients who recover normal left ventricular function at rest or with low-dose dobutamine can be allowed to taper and then discontinue heart failure treatment in 6 to 12 months. Natural course. Had a good prognosis, with a 94% survival rate at 5 years. Return of heart size to normal within 6 months. 54% recover normal left ventricular function. Prognostic factors. QRS duration of 120 ms or more is a predictor of death. Troponin T measured 2 weeks after the onset of peripartum cardiomyopathy predicts LV function at 6 months. QRS duration of 120 ms or more is a predictor of death. Troponin T, who et al. 41 reported that their serum cardiac troponin T concentration measured 2 weeks after the onset of peripartum cardiomyopathy correlated inversely with their left ventricular ejection fraction at 6 months. However, the sensitivity was low. A troponin T concentration of more than 0.04 nanograms per milliliter predicted persistent left ventricular dysfunction with a sensitivity of only 55%. The specificity was 91%. QRS duration of 120 ms or more has been identified as a predictor of death. Prolonged QRS duration has been shown to be an independent risk factor for death and sudden death. In a large series of patients with ischemic and non-ischemic cardiac failure. 77. Factors predicting normalization of left ventricular function. Initial left ventricular end diastolic dimension of 5.5 cm or less. Left ventricular ejection fraction greater than 30%. Risk of persistent left ventricular dysfunction. Left ventricular ejection of less than 30%. Left ventricular end diastolic dimension greater than 5.6 cm. Left ventricular thrombus. African American race. Recovery was more likely in those with an ejection fraction greater than 30% at diagnosis. In contrast, in Haiti, the death rate was 15. In contrast, in Haiti, the death rate was 15.3% during a mean follow-up of 2.2 years, and only about 28% had regained normal left ventricular function at 6 months. Risk of relapse. Even after full recovery of left ventricular function, subsequent pregnancies carry a risk of relapse of peripartum cardiomyopathy. Patients who recover normal left ventricular function and have normal left ventricular Contractile reserve after dobutamine. Challenge may undertake another pregnancy safely, but they should be warned of the risk of recurrence even with fully recovered left ventricular function. Recommendations for further pregnancies. If left ventricular function has recovered fully, subsequent pregnancy is not contraindicated. If left ventricular function has not recovered at all, the risk is high, and subsequent pregnancy is not recommended. If left ventricular function has recovered partially, then perform dobutamine stress echocardiography. Normal response, allow pregnancy. Abnormal response, risk is moderate, pregnancy not allowed. Take-home messages. Heightened suspicion is important when a pregnant woman presents with signs of heart failure. Standard heart failure therapy should be started in postpartum patients with this disease. Pregnant women should not receive angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, or warfarin in first trimester because of potential teratogenic effects. An initial left ventricular end diastolic dimension less than 5. An initial left ventricular end diastolic dimension less than 5.5 cm, a left ventricular ejection fraction greater than 30%, and a low cardiac troponin level may predict a better outcome. Subsequent pregnancies carry a higher risk of relapse, even in women who have fully recovered left ventricular function.